Good morning, good afternoon, and good evening to all of you who are joining us in this session of the 10th EDCTP Forum. My name is Dr. Fabiana Alves. I'm the head of Leishmaniasis program at the NDI, and today I'm stepping in for Dr. Natalie Stroop, the NDI director for neglected tropical diseases and COVID-19, who unfortunately was not able to join us today. So it is my very great pleasure to welcome you all to our symposium, Addressing Equity Challenges in Health for Neglected Populations. At the NDI, the Drugs for Neglected Diseases Initiative, we are working with partners to tackle therapeutic neglect. As you know, poverty and lack of access to healthcare are important obstacles to treatment, but even when patients do have access to good care, if there is no access to effective, safe, and affordable drugs, these patients remain neglected. It is no secret that for the neglected tropical diseases, with the word neglected part of their name, we often struggle to treat these patients. Sometimes this is because available drugs are toxic, difficult to administer, or not very effective. Affecting the poorest population in the globe, these diseases have not traditionally been interesting to pharmaceutical companies. But it is less obvious when we talk about HIV, a disease for which most major drug companies have developed effective treatments. For these patients with advanced HIV disease, a common cause of death is cryptococcal meningitis, for which there is effective treatment, but in a formulation that is very difficult to administer to such severely ill patients. So today in this seminar, you're gonna hear more about our work with partners to tackle therapeutic inequities in some diseases like sleeping sickness, to be presented by Dr. Antoine Tarral, in cryptococcal meningitis, to be presented by Dr. Isabella Ribeiro, and I will be presenting on our progress over the past years in the field of Leishmaniasis. I also would like to thank Dr. Anthony Solomon, Chief Scientist, Control of Neglected Tropical Diseases at WHO, for replacing Dr. Muele Malesela, who was unfortunately not able to join us today. So Dr. Solomon will kick off the program with remarks on the progresses and challenges in meeting the NTD roadmap goals. So we are going to start now the pre-recorded sessions for this seminar. And I would like to invite you who are joining us here today in this session to add your comments or questions in the chat in the discussion forum, hoping that we're gonna have a few minutes at the very end to have some Q&A sessions with you. Thank you very much. So we can start the recorded videos. Thank you.
Hi, I'm Anthony Solomon. I'm stepping in today for Dr. Muele Malesela. Thank you very much for the opportunity to take part in the session. I'm really delighted to be able to talk with you about some recent developments in work against the neglected tropical diseases. This is a time, as most of you know, when infectious diseases and their consequences are very much in the minds of people around the world. NTDs have been around for years, but rarely in the public consciousness. The burdens they inflict on people are terrible, ranging from discomfort to disability to death. And while the world has been engaged in the fight against COVID-19, NTDs have continued to wreak havoc on hundreds of millions of lives. For some diseases, those effects have been even more than they were before. We've heard a lot recently about the need to better construct the post-COVID world. It's my belief that tackling NTDs is a tangible contribution that we could make to that goal by treating patients, relieving suffering, and addressing the root causes of disease, and ultimately reducing and eliminating transmission of infection. NTDs, as many of you know, are a group of 20 or so very diverse diseases and disease groups. Some are parasitic, some are bacterial, others are viral, Another's a protozoal. One, that's snakebite envenoming, is a non-communicable disease. The fundamental thing that binds them together is that they're diseases of poverty. They disproportionately affect the poorest communities in the world. So were we to ask why NTDs have not yet been eliminated, a simple answer would be to say that we haven't yet eliminated poverty or the material conditions that contribute so powerfully to these diseases' prevalence. My intention today is not just to talk of the problem, but also about solutions, because there are simple, concrete, and cost-effective ways in which we can break the cycle of inequity that's shown on this slide. Investments in NTDs are some of the most economically effective of all those available to us in global health. Treatments for many of them are incredibly inexpensive and deliver powerfully effective results. You can see some crucial interventions here. On the left-hand side of the slide, we see how the preventive chemotherapy and vector control interventions can treat nascent infection, reduce the risk of exposure to infection in others, and break the cycle. Similarly, disease management approaches are getting better all the time for many of the 20 NTDs, enabling more and more people to be diagnosed quickly and to receive treatment. There are also more general ways in which we can help to reduce the burden of NTDs by ensuring the interconnectivity of our work with that of other sectors, for WASH, for example. The first global roadmap for NTDs was published by WHO in 2012. It put in place a strategy that would take us through to 2020, and it achieved some remarkable successes. Today, compared to 2010, some 600 million fewer people need interventions against NTDs, and 43 countries, territories, and areas have eliminated at least one of the 20 diseases. Lymphatic filariasis and trachoma have been eliminated as public health problems in 17 and 11 countries, respectively. Onchocerciasis has been eliminated in 4. The annual number of reported cases of human African trypanosomiasis has fallen from more than 7,000 in 2012 to fewer than 1,000 in 2018, eclipsing the original target of going below 2,000 cases by 2020. Much of that progress has been stimulated by pledges and commitments arising from the 2012 London Declaration on NTDs. With the help of dedicated partners, donors, pharmaceutical companies, and NGOs, and under the leadership of national health ministries, more than 1 billion people worldwide received treatment for NTDs every year from 2016 to 2019. Community drug distributors are generally used to deliver those drugs into communities, and those community volunteers have also been a major part of the response to COVID-19, further showcasing their importance to good community health. However, it's important to recognise that we didn't meet all of our 2020 targets. The excellent progress that was seen in some areas was not always balanced by excellent progress elsewhere, and we didn't get to the finish line for any of the 20 NTDs. In 2019, as the 2020 end date for that first roadmap started to approach, it became time to take stock and reflect. The NTD department at WHO now had 20 NTDs to oversee, many more than at its inception in 2005. As diverse a group of diseases as ever, there's also great disparity in terms of the stage of progress of control in the various disease areas. For example, the lymphatic filariasis program, which is validated elimination as a public health problem in 17 countries, is relatively well funded and has strong political support. The mycetoma program, on the other hand, doesn't have an actual program. It was important then to undertake a period of reflection so that we could see what could be learned from the more successful disease-specific programs and what might be leveraged to support the newer ones and those that were lagging behind a bit. Mostly, what we tried to do was take the opportunity to learn from our failures and ensure that we could do better in the future. That's really what the roadmap is intended to be, a strategy that will take us forward. It was written by and for the global community, that community of people who work directly in NTD programs. Its targets are undoubtedly ambitious, but they're also rigorously based in the available evidence, as our understanding of certain diseases has increased. The new roadmap calls for 3 fundamental shifts. Many of you have heard this before, but it's important, I think, to think about it often. Firstly, it asks for a move from measuring process to measuring impact. That means that we'll focus on accountability and on making sure that everybody in the chain works in a unified manner, so that we can ensure the success both of individual disease programs and the overarching management of NTDs. Second, it's more and more apparent that many of the simple and cost-effective interventions needed to combat some NTDs might be achieved more efficiently for more people with better collaboration. That means a shift from top-down planning and programming to collaborative work across sectors to make sure that as many of the different pieces of the puzzle are combined in the service of a common goal. Third, we all want to see endemic countries take the lead with regard to decision-making. The shift from partner-driven to country-driven programs means that all of our work will now be focused on the areas, the communities that most need interventions, meaning that programs will better reflect on-the-ground requirements rather than policy decisions that are made at a distance. To give you an idea of some of the targets that have been set for 2030, by that year we intend that 90% fewer people will require interventions against NTDs. There will be 75% fewer NTD-related disability-adjusted life years incurred each year. We plan for 100 countries to have been able to eliminate at least one NTD, and we want to see the total eradication of 2. That's dracunculiasis and yaws. We also have specific targets for increasing collaboration that I talked about before. Those range from integrating interventions so that one treatment round covers as many diseases as possible, increased adoption of specific skin NTD strategies, and ensuring that at least 90% of countries have integrated NTD interventions in their national strategic plans. The potential for collaborative effort is also huge when you consider the enormous benefit to health that accrues from better water, sanitation, and hygiene. We now have to work really, really hard to integrate NTD activities and interventions into broader health systems based on the principles of universal health coverage. That's at the very heart of the SDG health agenda, which holds that UHC is essential to promoting physical and mental health and well-being and to extending life expectancy for all so that no one is left behind. The new NTD roadmap as a tool has been developed with precisely that in mind. It sets out a blueprint that will enable us to ensure that all our efforts achieve the greatest possible impact. And that takes me back to the theme that I mentioned at the beginning, particularly the ways in which tackling NTDs can become a byword for tackling larger structural health and social problems. So many of the SDGs are relevant to the interventions required and carried out to combat NTDs. In many cases, NTD treatments are a precursor to or the first step towards the universal health coverage that impoverished communities so desperately need. Many of you know that NTD interventions are a community's only contact at the moment with formal health services, precisely because the interventions that we offer are able to get into the community, into remote villages and nomadic settlements. That immediately suggests ways in which many other health services can be provided to hard-to-reach populations in concert with what we do for NTDs. Services so basic that many of us really give them scant thought. And yet we've seen over the course of the last year that actions as simple as washing one's hands regularly with soap and clean water can have a profound effect on the prevalence and transmission of infection. As for many other programs, implementation of NTD work has faced a major challenge in the context of the current pandemic. And we can anticipate the impact being pretty profound. The landscape of global health is likely to change for a long time. failure to control or eliminate NTDs will be a direct reflection of our inability to respond to the needs of the most disadvantaged and neglected populations. So we hear a lot about building back better, but as was so eloquently put in a recent paper in the BMJ, NTDs are the barometer that we need to monitor to look at our progress in that effort and make things better in the future. The new NTD roadmap gives us a way forward for the next decade. It'll help us to reach eradication, elimination, and control of 20 diseases, harnessing the best of our current practice, learning from our mistakes, driven forward by countries and upheld by partnership. It's a sustainable plan, and I believe that it will empower people and communities at every step along the way. We'll strive to beat these diseases and contribute to achieving greater equity and opportunity, because we owe nothing less to the global community. Thank you very much again for the opportunity to contribute to this session.
At the beginning of 2020, fexinidazole, the first all-oral treatment for sleeping sickness, was rolled out in the Democratic Republic of Congo. We start in France, where the treatment was produced and released by Sanofi. Donated by Sanofi to the World Health Organization, fexinidazole is then shipped to the Democratic Republic of Congo by Médecins Sans Frontières Logistique. DNDi and the National Sleeping Sickness Control Program have trained medical staff on how to use the new treatment. Fexinidazole is now ready to be given to patients. It is shipped to the remote areas of the DRC, where people are most at risk of being bitten by the tsetse, which transmits the disease. The treatments arrive at Badundu Hospital, which was one of the sites where the clinical trials for fexinidazole were performed. Some boxes of fexinidazole are stored in Badundu Hospital, but the others have a longer journey. The next destination is Mushi, a town further down the Kwilu River, one of the tributaries of the Congo River. The previous treatment for sleeping sickness was bulky and heavy to transport, but fexinidazole is light and easy to carry. At Mushi, the first patient to receive the treatment is a young boy, Guy Bogongo.
Merci na question nayo. Mwana naki naye. Na mwana 12 ans na mwana parti. Tantini za beba na bitenda na pesa mingi na baza pepa. Mingi na bisi malamu ndi tona docteur mwana amela bakisi. Ngade bana ka patala ba pongi ti ta ma parti le dire ya 6 mois bitete na mingi nga. Ndo memeti ana mushawa.
Guy will receive treatment for 10 days with food. Previously, treatments required almost 2 weeks of hospitalization with IV infusions twice a day. Back in Badundu, Papa Jean was the first patient to receive this first oral treatment.
Mume bela ntangu yanda, muvanda wa ntumpasi, muke wa des fois mufeti katula bilele, muke wa nitu bien fait. Muke wa kutoka mingi, nitu ke permettre muna kutambula mbote ve.
Muke pesa beno merci, sambu ben ba docteur me kwa system mume baka bankisi.
The journey to get the treatment from the laboratory into the patient's hand has been a long one and is testament to strong partnerships between Sanofi, DNDi, the DRC Sleeping Sickness Control Program, and many other partners. It is also a testament to the power of innovation in fighting neglected tropical diseases. But it is all above a testament to the will of Congolese sleeping sickness doctors to deliver appropriate treatments to their patients. Their call has been heard, and thanks to their work, fexinidazole has arrived.
Hello everyone, I'm Antoine Taral, the head of the HAT clinical program at DNDi Geneva. I'm pleased to present you the new treatment of the human African trypanosomiasis, also called sleeping sickness. Here in this slide, you can see the different treatments who have been used so far in or will be used in this disease. 15 years ago, the treatment was based on an arsenic-based compound called melarsoprol. This treatment was feared by the medics because the treatment itself can lead to death, and it was also feared by the patients, which was a reason that the patients comes late to the treatment in a hospital for this disease. In 2019, the DNDi registered a new compound called NECT, which is a combination of infusion of eflornithine, 2 hours infusion per day for 7 days, plus nifurtimox, which is an oral treatment. This combination was introduced in 2009, and it was a real revolution in the treatment for 2 reasons. The first one, there was no one who died during the treatment or due to the treatment, and the success after treatment was very high. This treatment had so far over 93% success. The main weak point for this treatment was the logistic. We have to prepare for all treatment, all the necessity needs for infusion. And you can see in the slide the number of equipment we have to be put in the packaging when we start with this treatment. The weight of the packaging was around 40 kilograms to treat 4 patients, and that was sometimes very difficult to bring this treatment to the right patients. DNDi continued their research in oral treatment, and in 2018 we was able to submit to the authorities a new oral treatment called fexinidazole. It was a 10 days treatment, once a day ingestion of the pills and with food. This treatment was also registered by the FDA in July 2021, and it is now used as the primary treatment in the first-line treatment for this disease. The next step where the NDI is working is a new oral treatment, which is one single administration for this disease, and we have so far some results which make us thinking that this acoziborole could be the future treatment for this disease. In this slide, I can show you what the WHO has presented recently in the HAT platform meeting, which is in fact the goal of, or the target of 2020 of WHO, which was to reduce the number of patients detected and treated in 2020, or less than 2,000 patients in each country. But you can see in this slide that the decrease was much faster due to the activity which has been done in the field, and DNDi participated in this high activity, and all the national sleeping sickness control program too. You can see there is a huge reduction, 98% reduction in the number of cases. The horizontal line gives you the number of cases in 2020, which was around 663 patients detected and treated. The majority of these patients were sleeping sickness gambiense trypanosome related, and only 3% of the patients were the other type of the disease, which is the rhodesiense trypanosome, and this represents 3% of the patients. So far, WHO has reached, in collaboration with all the partners, the target of 2020. In the future, there is a new goal, 2030, where we wanted to, where WHO is aimed to decrease the transmission of the disease. And you can see in this slide that there in the circle that there are different activities we need to be focused on. The first one is this passive case screening, passive case detection. the patients comes more and more by themselves to the hospital, we need to have new diagnostic tests, especially new rapid diagnostic tests or some ELISA, which these two tests can be more selected and more sensitive in the screening. And WHO is also, and the partner are working on molecular biology tools, which means new tools which can also be used as a test of cure. These tools include all the RNA PCR, multiplex PCR, or digitalized PCR. The second activity we need to improve is the active case detection, which is a huge activity, needs a lot of skilled technicians going to the field. And here also we need to improve the way they work, having more mobile teams or increasing the number of mobile teams or mini mobile teams, having door-to-door screening in some village, and also better targeted the results and targeted the activity by digitalization apparatus or tools we can implement it in this active case detection. The third one is the case management, that is the treatment of the patients. And here we have, of course, now I told you the fexinidazole, which is now first-line treatment, which is an oral treatment. We can go closer to the patients. And in the future, we will have this single oral dose acoziborol, who can facilitate also the access to the patients. And then other goal for WHO is also the Rhodesiense, called here RHAT, which is now where the NDI is in which the NDI is doing some studies. One study in this Rhodesiense with fexinidazole, and the results are extremely encouraging. Really amazing results of fexinidazole to cure this disease. And then we need in the future to see if we can extend the treatment to patient at risk. And this is for normally new test of screening and new treatment, and simple treatment, and acoziborol could be this simple treatment. And then we need also to see how we can control the vector, which is this tsetse fly. And here is an activity on tiny target and community involvement, which will be the main focus to reach this better results in the vector control. So regarding the conclusion of this new treatment, so the NDI cares about neglected disease in collaboration with some partner and in collaboration with WHO. So WHO has two main goals: to interrupt the transmission of Gambiense HAT, the main sleeping sickness patients, having a sustained elimination by 2030, and the NDI. The contribution of the NDI in this goal is to develop acoziborol for the extent use in the population at risk, including children. And the second goal of WHO is to keep Rhodesiense HAT, the second sleeping sickness disease. And we wanted to participate in this elimination as a public health problem in 2030. And here, fexinidazole has shown very good results in this study for this indication, and we wanted to register fexinidazole in this indication. Thank you, DNDI. I want to thank EDCTP for their support in the HAT development and all our other founders and partners. Thank you.
I was a cryptococcal meningitis patient diagnosed in 2019. When I came to the hospital, I had severe headache, a stiff neck, and I could not see with my eyes. It was so painful, I thought I was going to die. The headache was very bad.
So cryptococcal meningitis is the second leading cause of death in people living with HIV after TB. Managing patients with cryptococcal meningitis is obviously both very difficult for the patient and very time-consuming and labour-intensive for the healthcare workers involved.
When they started giving me treatment, I took the medication, but my problem is I was vomiting. So I wasn't sure whether the medication are getting in my system properly or what, but it took me time to say that the headache has disappeared.
Treatment needs to be more accessible, which means also more affordable. Patients need to be able to get, at the very least, the current WHO recommendation, which many, particularly in sub-Saharan Africa, don't. And then those treatments need to be improved upon. Flucytosine is oral, which is great, but at the moment it needs to be given every 6 hours. So a sustained release formulation, a formulation that could be given twice or ideally even once a day, would go a long way in improving patients' adherence to the medication, the tolerability of the medication, and probably outcomes. Having access to medication in the places where it's needed would go a long way in reducing those 180,000 annual cryptococcal meningitis deaths.
I was very happy to see that the medication is working. I feel absolutely like a normal person right now. And I don't have any fear of getting sick or dying at this point. Treatment can save your life.
Hello, my name is Isabella Ribeiro, and it's a pleasure to be here today presenting on this 10th EDCTP Forum on Equity in Research for Health. I'm presenting on behalf of the 5FC HIV Crypto Consortium on our project on improving cryptococcal meningitis treatment for people living with HIV. Like many diseases, HIV is one that thrives in inequity and inequality. Significant progress has taken place in improving access on antiretrovirals over the past decade. However, persistent and large burden of HIV-associated morbidity and mortality remains. As an important underlying cause, we have that of health system failures in antiretroviral rollout in resource-limited settings. Some regions of the world and certain communities, populations are disproportionately affected. If you speak about geographies, the majority of people living with HIV are in low and middle-income countries, sub-Saharan Africa being particularly affected with 80% of the global HIV burden. To reach global health targets in HIV, it's key to address poverty and persisting inequities. Cryptococcal meningitis in itself is an indicator of health system failure and existing inequities. 1 in 3 people living with HIV present to care with advanced HIV. And among the most common causes of death, we have that of cryptomeningitis. Antiretroviral scale-up, it's ultimately a key element in reducing cryptococcal meningitis mortality. And that has been demonstrated in Europe and North America. In contrast, what we have is a burden of morbidity and mortality of cryptomeningitis in lower middle-income countries remaining largely unchanged. Retention care is actually another very important dimension, with over half of cryptomeningitis cases now occurring in patients that previously prescribed antiretrovirals and default. So as countries move toward expansion of HIV treatment programs, cryptomeningitis serves as this important indicator disease for national programs. It's a disease that affects hundreds of thousands of HIV patients with advanced HIV every year, and it's responsible for about 15 to 20% of AIDS-related deaths. It ranks among the most poorly funded neglected diseases in the world, at the same time being the most common cause of meningoencephalitis in sub-Saharan Africa and Southeast Asia, disproportionately affecting populations in some of the most economically disadvantaged regions in the world. Mortality rates remain high, ranging between 20 to 70% with treatment, and up to 100% without, affecting at the same time some of the most economically productive age groups. So there are diagnostic and medicines for prevention and treatment, but access in resource-limited settings is extremely limited. High-dose fluconazole remains among most commonly used treatments in low-income settings, resulting at the same time in about 20% survival. So there is this clear imperative to scale up the rollout of advanced HIV WHO-recommended packages of care. At the same time, we need innovation. WHO placed innovation as a major pillar in its strategy to achieve elimination of HIV as a public health problem by 2030. And in one hand is innovation in research and development of new improved diagnostic and treatment tools, but also on improved diagnostic and treatment approaches and strategies, thus how best to deploy existing and future technologies. This specific project, we're working on the development of a sustained release flucytosine formulation, aiming for simplified inpatient and outpatient treatment of cryptococcal meningitis, and thus targeting a reduction in mortality. Flucytosine is the oldest antifungal currently in the market, and it is at the same time part of the two of the first-line regimens recommended by WHO for cryptococcal meningitis. It is administered 4 times a day, with results in challenges for compliance in understaffed and overburdened hospitals in resource-limited settings. The current formulation is not adapted for use or dose adjustment, with really large pill burden and often crushed tablets, and required for management of a significant proportion of cryptomeningitis patients presenting without tolerating medicines by mouth over the initial days of treatment. And if one thinks about reduction in mortality in cryptomeningitis, there's consensus on the need for early diagnosis and treatment of cryptococcal disease. And for this, we need oral treatments to support early preemptive treatment strategies, of which the sustained release flucytosine can be an important component. We're presently working on pharmaceutical development of these prototypes for clinical trial evaluation, and really following the development of target product profile, really working these coated pellets to be dispersed before dosing via oral or nasogastric tube twice daily. Among the steps identified for clinical development and registration, we have a phase 1 program with 2 studies for evaluation of the comparative bioavailability of the sustained release prototypes versus the immediate release formulation of flucytosine in healthy volunteers. The phase 1 program is implemented in South Africa by one of the partner organizations, Pharmov in Bloemfontein. The phase 2 program is that of evaluation of pharmacokinetics and early fungicidal activity of the sustained release versus the flucytosine immediate release, both in combination with amphotericin B in patients with cryptomeningitis in Tanzania and Malawi. We're targeting WHO prequalification and registration in selected endemic countries, starting with the countries where the clinical trials are implemented. In parallel, as an important component of this project, and with the leadership from St. George's within this consortium, we have the work on access for flucytosine-containing regimens and for the implementation of WHO treatment guidelines. So we are working, in one hand, on capacity building for country teams, also engaging with industrial partner on registration of the sustained release, but also on the immediate release flucytosine and broadening the registration and availability. We are advocating together with partners for increased availability of these regimens. We have launched, together with the the Cryptomeningitis Action Group, a campaign to end cryptomeningitis deaths by 2030. Beyond, we're working with CDC, MSF, and also with the Engaging with CHI implementation project on advanced HIV. We have, as part of this EDCTP-funded consortium, this broad and strong partnership, leading different elements and work packages in this program. So at this point, I'd like to thank our partners, Pharmov, NIMRI, Luxembourg Institute of Health, UNC Project in Longwy, Malawi, and St. George's, and also the EDCTP for supporting the consortium efforts. Thank you.
Nilikonjeka kwa ugonjwa wa kalasa. Nikajaribu kutumia dawa za kienyeji. Hakuna. Hata zingine karibu kuniua. Nikaenda hospitali, nikapewa dawa ya malaria, nikatibiwa, hakuna.
Kuna watoto 9. Kati ya hii watoto 9, 4 ndio wamepata kalasa. Sasa kati ya hii watoto 4, mmoja ameaga.
Visceral leishmaniasis, also known as Kala-Azar, is a potentially fatal neglected disease with a worldwide distribution in Asia, East Africa, South America, and the Mediterranean region. Visceral leishmaniasis persists today in poor, remote, and in certain politically unstable areas, with over 200,000 to 400,000 new cases globally. Eastern Africa is the most affected region in Africa, with an estimated annual incidence rate of 29,000 to 56,000 cases. Many health facilities in the endemic areas lack the expertise and equipment to diagnose and treat.
Ukisipokimbiza kwa hospitali ambayo itakuokoa haraka, utaambiwa tu malaria, typhoid, mpaka wewe sasa utaendea hapo.
In 2003, the Leishmaniasis East Africa platform, LEAP, was formed with a mandate to build the capacity for clinical trials and deliver better treatments for Leishmaniasis patients.
This is a group of scientists together with institutions that came together and said, look, we need to work together. What is it that we need? What is lacking in terms of the treatment for patients for Leishmaniasis?
So as African researchers, clinicians, backed by the NDI, that entity was set up to do clinical research, specifically clinical trials.
LEAP draws its members from the endemic countries of East Africa, mainly Ethiopia, Kenya, Sudan, and Uganda. Working with academic and research institutions, governments and drug regulatory authorities, LEAP has managed to conduct over 10 clinical trials and set the standards for good research practices.
Thank you very much for the invitation to participate in this seminar. So this presentation is going to be on new treatments to respond to the needs of neglected patients affected with Leishmaniasis. So Leishmaniasis is a disease present in 83 countries. There is 1 billion people that are at risk of getting infection. Leishmaniasis is a complex vector-borne disease transmitted by these tiny sandflies, and it can present different disease manifestations depending on the Leishmania species that infect the patient. The most severe form is the visceral Leishmaniasis, which is fatal if it is not treated. As for other vector-borne diseases, Leishmaniasis is a climate-sensitive disease. It affects the poorest people on Earth, and it's also prone to outbreaks, mainly related to the displacement of vulnerable populations due to conflict. A classical example is the thousands of cases of death we had in South Sudan due to a VL outbreak. There is estimation of about 1 million cases of Leishmaniasis worldwide. Most of them are cutaneous Leishmaniasis, and there is also 14,000 deaths that are associated with Leishmaniasis estimated every year. If we now think about visceral Leishmaniasis, WHO estimates about 50 to 90,000 cases every year. Half of them are children. Currently, the highest burden worldwide is in Eastern Africa, where visceral Leishmaniasis affects mainly poor communities in remote rural areas. These are the current drugs to treat Leishmaniasis. They all have limitations of toxicity. Most of them are parenteral, and mutafosine, which is the only oral drug, it has the limitation of being a teratogenic drug. So Jan from the beginning, when we envisioned the strategies to develop new treatments for Leishmaniasis, we had the short-term and long-term objectives. In the short-term strategy, we looked at the currently existing drugs and how to improve treatments by combining them depending on the context of the disease in the different regions and for the different indications. But at the same time, we invested a lot in discovery of new compounds. So these are expected to be the new treatments that are going to be oral safe and therefore can be implemented at lower levels of the health system, much closer to the communities affected by leishmaniasis. I'm going to give you now some example of the work that we have been doing on visceral leishmaniasis. So this is, in this picture, we can see it is the current standard of care of leishmaniasis in Africa. It is a combination of sodium sivucocolate with paramomycin. It is an improvement over the past treatment, which was based on monotherapy with SSG, but still with the limitation of being 2 injections every day, very painful for 17 days. It also has a toxicity associated with SSG. It is not recommended for more than 50 years old patients due to lower efficacy and higher mortality. And also it is not recommended for patients co-infected with HIV and VL. Therefore, there was a need to improve this treatment, and the option was to replace the toxic SSG with oral mutafuzine. But we had to learn how to adapt this to the context in Africa. So we had to start with the experience in Asia, where paramomycin and mutafuzine given in the conventional dose were reaching more than 95% efficacy with a treatment of 10 days. When similar studies were implemented in Africa, we had actually much poor treatment response, and especially in the case of mutafuzine, when conventional dose was used, we had efficacy of as low as 72%, and mainly the children were the ones who were having failure, and this was associated with lower exposure to mutafuzine when given the conventional dose. So we had to do further studies adapting now these regimens. Paramomycin had to increase to a dose of 20 milligram per kilo, and mutafuzine, when given in an allometric scale, had much better efficacy of 90% in pediatric patients. Therefore, there was the recommendation that the new treatment should be, that to be tested should be a combination of paramomycin with the dose of 20 milligram per kilo and mutafuzine allometric dosing for 14 days. And this was based on some PK modeling. So this study had to be implemented, of course. So this was a large phase 3 trial, which was implemented in Ethiopia, Kenya, Sudan, and Uganda. We have completed this study. We are currently at the analysis stage. The results look quite promising. We had a very good treatment was well tolerated, and also the efficacy results are quite promising. So this is expected to be a better option treatment for children, especially in Eastern Africa. As I said, this represents more than half of the patients affected by VL in this region. Now going to another patient population, those who are co-infected with HIV and VL. These are patients that are the most difficult to treat in Africa, well, everywhere. So these are patients that require special care. Usually they have poor response to treatment, they have higher mortality, and they also have higher risk of relapse, which is associated with low CD4 count. In Ethiopia, there is about 20% of the patients who have both HIV and VL. And as I said, these are extremely difficult to treat, and therefore the NDI with MSF and also University of Gondar and other partners, we have conducted studies in Ethiopia to assess a combination of ambisome with mutafuzine, which gave very good results of up to 91% efficacy at the end of therapy. So this combination together with ART and secondary prophylaxis is now recommended to reduce risk of relapse, and also other drugs to manage the other comorbidities. This is currently under review by WHO and Ethiopia, and the revised HIV-VL guidelines are expected to be released by the end of the year. So these are examples of studies and new treatments that we have been working on, which are based on the improvements with the current drugs. But the big difference is going to come with the new chemical entities. As I said, we want to move from the current treatments, which are
toxic with variable efficacy and require hospitalization, to treatments that are going to be based on new oral short course therapies. These are expected to bring treatments that are going to be safe with high efficacy that would address, the needs for the patients that are affected by the different form of leishmaniasis in the different regions. These treatments are going to be adapted to children and also women of childbearing age. And by having a safe and efficacious treatment, we expect that these will be able to be deployed at the health centers closer to the communities affected by leishmaniasis. This would also have an impact on time to access to treatment, therefore reducing morbidity, mortality, and breaking the cycle of transmission. In summary, we expect that these new chemical entities are going to benefit not only VL patients, but also those affected by cutaneous leishmaniasis, post-Salazar dermal leishmaniasis, and also HIV co-infected patients. Thank you very much.
So I guess we have really reached the time of our session. I don't know, Isabella and Antoine, if you can come, put your camera on, just to, if you want to say a very final word to the audience. Again, sorry for the problem we had with the technical problem of the video. I really hope the video can be made available to all of you who may be interested to listen to the different presentations, and also with the additional material, which brings us closer to the patients. Bella, Antoine, any final sentence?
Just to mention to participants that we'll be happy to respond to questions, and if to follow up if you have. I try to monitor the chat and see, but please happy to through the forums that from today. We're happy to answer anything, but thank you very much. It was a pleasure to participate and present on the behalf of the consortium.
Thank you, Bella. Antoine, final word.
Thank you, Fabiana. So when I refer to Anthony Salomon presentation, we have a great hope now that there is a huge progress in the NTDs supervisions and concern, and we have reached a lot of success in the last 10 years. So hopefully we can continue to maintain this success in the next few years. Thank you for your participations.
Thank you so much, Antoine. Absolutely, and I think we are all here united to combat the note and to have better future for these patients, bringing new tools, and again thinking really about this integration and having the local leaders as the ones who are going to push these efforts forward. So thank you so much for all of you who stayed with us until the end, and have a good day.
Bye-bye.
Bye-bye.
Thank you again.